What happens when the trauma victim is pregnant? Approximately 7% of pregnant women will suffer physical trauma during their pregnancy. The majority of this trauma actually happens in the second and third trimester. We only look at about 8% in the first trimester. On the other hand, of reproductive age women presenting with trauma, approximately 3% are pregnant, and 8% of whom did not know they were pregnant prior to presentation. In women of reproductive age that are involved in trauma, it is imperative to know if they are pregnant or not. If they are, we're doing medical imaging for two. There are many injury patterns that occur during pregnancy: motor vehicle accidents, slips and falls, burns or thermal injuries, electrical injuries, domestic violence injuries, penetrating injuries, and poison or toxic injuries. We often think of injury patterns in pregnancies as being from a car wreck or a fall, but unfortunately domestic violence plays a huge role in the pregnancy trauma that we see in the hospital. Everything from sexual assault to homicide and suicide of the patients afterwards. We often see battering and gunshot and knife wounds. If the trauma victim is pregnant, resuscitating the mother will resuscitate the fetus. Traumatic injury to the mother will often result in injury to the child or children that she is carrying while pregnant. Abdominal trauma can cause feto-maternal hemorrhage, uterine rupture, rupture of membranes, and preterm labor. From seat belts and blunt trauma to direct penetrating wounds or gunshot wounds, the abdominal injury is one of the major causes of injury to the fetus. Injury or abdominal injury can cause premature contractions. These rarely progress to preterm delivery. Unfortunately, placental abruption occurs in about 3% of minor trauma and up to 50% in severe trauma cases. Placental abruption occurs when the placenta either partially or completely separates from the uterus. Placental abruption can cause severe bleeding in the mother and partially obscure the respiration or oxygen intake to the fetus. Separating the lining of the uterus, which provides the child with oxygen, can cause a problem with mental and physical growth and even stillbirth. Although uterine ruptures are very rare with abdominal trauma, they do happen in about 0.6% of severe trauma cases. When the uterus ruptures, the mother and the child are both at risk of death. Maternal fetal hemorrhage causes isoimmunization and fetal death. This diagnosis is 4 or 5 times more common in the injured pregnant woman and occurs more than 45% of time in the last or third trimester, although it does occur during the first and second trimester. Vascular injury to the uterus is uncommon, largely because the vessels are located quite lateral and posterior in the latter stages of gestation. However, because of the tremendous volume of blood flowing through the uterine vessels, injury to these vessels is likely to result in rapid deterioration of vital signs. This depiction of the vasculature in the uterus shows us the difference between the first trimester, second trimester, and third trimester. Now let's take a look at diagnostic imaging, the pregnant patient, and trauma. Obviously, ultrasound would be our first choice and the most useful form of imaging, but we need to make sure that we utilize all of our resources to be able to demonstrate what is wrong and how we are able to help the patients. Patients because there's both a mother and child to help. Ultrasound is probably the best imaging modality to assess both the mother and the fetus. It is a safe procedure, and this targeted ultrasound assesses 4 areas of evidence of free fluid: the subxiphoid area, the right upper quadrant, the left upper quadrant, and the suprapubic area. Often we do need more than ultrasound because ultrasound is limited by the ultrasonographer skill and expertise. Let's take a look at an 18-year-old woman who was 14 weeks pregnant and had her seatbelt on but was T-boned by a high-speed motor vehicle crash. Due to the nature of the trauma, a CT image through the gravid uterus is normal, with anterior placenta and early ossification of fetal parts demonstrated. There is a small hematoma in the left pelvic sidewall due to a pelvic fracture. Although the placenta looked normal on the ultrasound, the next day a limited obstetric ultrasound image was obtained, and it demonstrated fetal death with intrauterine gestation with no fetal cardiac activity. We often need more than one type of examination for a diagnosis. I can see you saying, oh my gosh, they did a CT. Look at all that radiation. What if we did a plain film? Wouldn't we also have a lot of radiation? Let's get real. First of all, we have to look at why we're doing the exams and what is the risk to benefit ratio. Sieverts is the amount of exposure, where gray is the amount of radiation that was absorbed. Less than 100 millisievert, or 100 milligrays, poses no risk of congenital malformation, intrauterine growth retardation, or childhood cancer. We find that the nonlinear threshold dose, which we use for many, many years, is inaccurate, and it was formulated in the 1940s. The ionizing radiation we use today for our modalities is much less than in the past. We have a low-dose spiral CT, which produces much less radiation than a traditional CT, and normal X-ray or plain X-ray has been taken over or replaced by digital X-ray, which allows us less exposure and more information. The old standard of the nonlinear threshold dose, which meant any X-ray could cause a problem, has been scientifically proven wrong. What we know today is that if judiciously used, ionizing radiation will harm neither the mother nor the child. In addition to ultrasound and X-ray, we may use MRI, magnetic resonance imaging, that gives us soft tissue information. The MRI may be required for certain traumas, such as spinal cord injuries and soft tissue injuries. MRI has proven to be safe for infants for more than 20 to 30 years. Caution should be used when utilizing MRI contrast to image the fetus. Oxygenation of the fetus is extremely important, and one of the things we need to be sure is that we are positioning the patient so as not to cut off the blood and oxygen supply to the fetus. If this happens, the fetus will drop heart rate in response to the hypoxia or lack of oxygen, and the uptake will be proportional to the placental blood flow that has been cut off. Remember, we are positioning for 2, and a pregnant woman beyond 20 weeks gestation should be placed in a lateral decubitus or about a 30 degrees lateral tilt to prevent supine hypotension. In other words, to have the weight of the fetus pressing down on the blood supply. When we compress the aorta, we're able to cut off the blood supply, so therefore we want to get the weight off of the aorta by a lateral decubitus or by rotating the patient about 30 degrees. This is Mark Struthers saying thank you for watching, and we hope to give you more information soon at Medical Imaging Tutorials.